Thanks very much. That was incredible, actually. I'm sure many of you, I was kind of writing down things as I went about, how informed Joe was. And I think Joe could probably teach some of our registrars something about mesothelioma. He's obviously done an awful lot of his own research. And, I think that speaks really to how engaged, so many of our patients and families are, and how much they want to improve their own outcomes, and that partnership is so important. And there's some things for us to learn, I think, there, maybe trying to make the website a bit more visible, so that that tailored information is available, and we'll take that on. But that was really interesting and brave to hear from Joe, and a big thank you from me, and I'm sure from everybody, for sharing his experience. So we're going to move on to hear from Clinton Alley next. So Clinton is a medical oncologist. So he is a cancer specialist his main role is in deciding about what drug therapies to use for cancer. So Clinton, I'm sure you'll enjoy his talk. He has a lovely West Indian accent. I was reading his bio there. I didn't realise he was actually a cricket instructor as well. I don't think that'll come up, but I'm sure it'll all be mesothelioma. But I'll pass you over to Clinton, and then we'll come back for a Q&A session at the end.
Thank you, Kevin, for the kind introduction. Thank you to the network for having me on to say a bit more about mesothelioma and the trials we've had and the treatments that we had and now have. It's an exciting time for all of us. So as you know, I'm from the Beatson, the cancer center itself. I work with some brilliant colleagues here at medical oncology consultants and clinical oncology consultants, and a broad range of the MDT and specialists who support us. Just some disclosures there about previous meetings and so. So as you know, mesothelioma, as Kevin highlighted at the start of the meeting, it's been quite a uphill challenge for many patients. And remember, a lot of these patients who are diagnosed with mesothelioma, men mainly, have worked very, very hard in all their lives, and certainly may have other medical problems as well too, medical challenges. So it's a tough road, with the diagnosis and what you do with treatments and how fit you are to have treatments and so on. So we've had this challenge over the years, and in the times when we started treating mesothelioma, we had a lot of patients requiring supportive care, probably because they wouldn't be fit for much more. And it's unfortunately still the case where patients may just need supportive care and time with their family. But things got a bit better, and we noticed that platinum chemotherapy was quite helpful for some patients who were suitably fit. And the combination of platinum chemotherapy and pemetrexed on trials back then too showed some promise for improving the outcomes for patients. But even after that, there was still no second-line treatment options available, and patients will be offered supportive care after, even if they did well after chemotherapy. So chemo became pretty much a standard of care back then, based on the phase 3 trial utilizing pemetrexed in combination with cisplatin, which was proven on this particular study by Vogelsang, and cisplatin was the standard of care at that time, so that was the standard arm. And there were 450 patients in this study. It clearly showed a median survival improvement of just over 12 months compared to 9 months in the control arm, with response rates of over 40% compared to 16%. So this became the new standard of care around 2004 time, if I remember rightly. I was probably a first-year registrar at that time. I don't know what Kevin was at the time, and Selena. I was probably in our earlier days of training, etc. But that was about 18 years ago, so that's quite some time. And again, mentioning supportive care if patients had progression as the only other option. So we can see there, that's an example of a survival curve. It's not the most beautiful, it's black and white, but it does show you that the combination arm, cisplatin pemetrexed, did do better than the standard arm. And that's why we talked about things like median survival. These are terms we tend to use in oncology, and gives us doctors a good idea of what's benefiting patients and what's not benefiting patients. And we use a lot of statistics and so on, a lot of which some of us will still struggle with, but statistics is very important to help us understand what is significant and what is less significant. So in the present now, we're quite fortunate that we have new trials as per the Mesothelioma UK website, and I'm sure you've all visited the website at some point. There's emerging and new data. As Kevin mentioned already too, there's SMC reviews and updates, and even in England, nice reviews and updates. So our colleagues down south may be doing similar to us in some ways, and maybe doing slightly different based on these updates and approvals. Data is awaited in resectable mesothelioma, in particular based on the MARS-2 trial, and that's an exciting time for us as well too, which is coming. There's guidelines that will change with time, but most importantly, we're seeing an improved diagnostic pathway for all patients, with open discussion and options to explore with patients and their families the best treatment options in terms of what we could be offering and what we shouldn't be offering also. So it's very, very important that we get that quite clear, and that awareness of patients and family, I think we welcome that, because it does open the challenge for us as a professional society, that we need to make sure we have clear plans and accept the challenge that we have to put a lot together and apply a lot of information to know how we best optimize or improve the outcomes for patients. So team working, ever so more, even during the pandemic, I must say, in my own experience, has become even closer and tighter. And despite the challenges of the pandemic, we have continued to recruit to trials and report trials and get treatments now coming through for patients, which are, as you'll see later in my talk, improving. So we clearly need clinical trials, and this is a bit of information from the CRK websites, and trials tell us a lot. Some trials will show that a new treatment works better than an existing treatment, as I've given an example of earlier. Others will tell us more about the side effects or what happens to the drug in the body of the patient. Not all clinical trials will result in new and better treatments, but however, that still is quite useful for all of us to know if a trial is negative. The treatment being tested may not work, or it may have side effects or a risk to the patients that are felt to not be worth it. All of the information, as I said, is very useful for researchers, doctors, and in the end, for the patients and the families. There are two main types of clinical trials, just to recap here. When we had this meeting last year, I remember we talked about it, and Dr. McKean gave a lovely presentation as well, to just reminding us all about the basics of our clinical trials. And most of these trials we refer to are interventional trials, which aim to find out more about a particular intervention or treatment. And quite often these trials are involving what we call randomizations. And yes, sometimes computers do decide which arm a patient may be randomized to. And that's the basis of what we call randomized control trials, which make up a very important bit of our studies. Observational studies are also very important to mention. But just to touch on this briefly, it's quite a detailed slide, apologies. But again, we did speak previously about the different phases of trials and very early phases of trials. The majority of trials we tend to get involved with, certainly at the Beatson, tend to be the phase 2-3 trials for mesothelioma. And as you can see there, as you get to phase 1 to 2 to 3 to 4, the numbers get bigger. Quite often you'd be seeing a lot more in terms of numbers of patients, and the involvement with the trial and the duration the trial will continue for, and whether or not it's a randomized controlled trial. All the people involved in the trials, we're all very much governed by something called good clinical practice. And that's from everyone, from data managers, the nurses involved, the doctors, the radiologists, everyone. And we have to conduct the trials in a particular way. They're usually performed at specialist oncology centers like the Beatson, or associated linked hospitals may also be involved as well too. So I'm getting to this point where we were in the past, we're now starting to see a bit of light at the end of the tunnel here. There's clearly something happening for mesothelioma, and we can start thinking a bit more positively of how we can think about different treatments as well, based on newly reported positive trials. I'm just going to mention, already mentioned, based on the previous talk, a lovely case example, gentleman on Checkmate 743 trial data going on to have immunotherapy. And just to remind you that even in the second and third line settings, we have treatments we can consider based on other trials, such as the CONFIRM trial and the VIM trial, CONFIRM utilizing nivolumab, which is immunotherapy as well, and the VIM trial utilizing a form of chemotherapy called vinorelbine. Before I get to those positive trials, I just want to mention that we still have trials on the go, and we are waiting data for some trials and the outcomes. And some trials have come and gone. Some trials in Scotland we've had open, some have closed now. Some of the trials just mentioned briefly in England have closed now, closed during the pandemic even. The MARS-2 trial we'll mention again too. That's an early stage mesothelioma. And again too, that was closed in October 2020 and still managed to recruit during the pandemic. Atomic Meso recruited very well again too in Scotland and the UK, and that was closed recently in August 2021. The NEMO trial, another trial conducted in England, not in Scotland. The Beat Meso trial, likewise similar in England, and the MIST trial, which continues to recruit. There's something really quickly about these trials. So the Atomic Meso trial we did take part in Scotland, and it's certainly open here at the Beatson. And it still managed to recruit in the UK a reasonable number of 144 patients. And this was utilizing a novel drug, an enzyme blocker, that kind of works along with the chemotherapy to try to enhance particular groups of patients with mesothelioma and to see whether or not in these patients they may do better. We don't know the results of the trial yet, but there were a total of about 250 patients who internationally were recruited. It did fall short slightly of the recruitment figure, but obviously the pandemic had a big role to play with that. They mainly involved patients with biphasic and sarcomatoid histology as opposed to epithelioid histology. So we'll hopefully hear something more about this trial later in the year. The NEMO trial, nothing to do with Disney, was a trial that looked at a particular drug called nintedanib, and after completion of chemotherapy, this was conducted down in the London area, and they utilized the drug nintedanib, which is a blood vessel blocker, what we call a VEGF inhibitor, so it blocks vascular growth. So they tried to see whether or not this trial may actually, with the addition of this drug, improve the control for patients with mesothelioma after having had chemotherapy. Now, that trial is now closed now, and we'll be reporting a bit more detail later. The Beat Meso trial, likewise, was an interesting trial. Again, this was utilizing immunotherapy. This was due closure just about last month, and again, too mainly conducted in England. And it utilized immunotherapy drug called atezolizumab in combination with another form of a blood vessel blocker, a VEGF inhibitor called bevacizumab. And it was done together with chemotherapy to see if it can improve the outcomes for patients who were treatment naive with advanced malignant pleural mesothelioma. So again, too, that's an interesting study that we'll wait for the answers and reporting, but equally too, how relevant is it to us? We didn't conduct the trial in Scotland, in fairness, but we now have immunotherapy in Scotland, so maybe less relevant to us, but it's still interesting to see the results of these trials. A lot of work and energy, and patients have gone into these studies, so we still have to wait and see. Maybe there's something we can learn from these trials as well. This is very interesting, and again, to the MIST study looking at mesothelioma and the stratified therapies. This is part of the British Lung Foundation, was funded. It's a stratified therapy-based trial looking at patients who've had treatment before and relapsed with mesothelioma. The University of Leicester and Professor Fenella conducting this down in the south. The goal of the trial is going to ultimately enable potential new therapies or novel therapies to be accelerated based on a very much personalized therapy approach. And it's quite a complex trial, and a lot of us are still trying to get our heads around it. It maybe even be updated in a new version. But we really ultimately like these trials because it would allow us the opportunity to see if we can personalize patients' treatments based on specific markers or specific measurements within the tumor, to help us try to direct or target therapies a bit better, and ultimately, hopefully, offer treatments that probably have less side effects, equally too with better outcomes. So that's an exciting bit that we probably need to look out for as well too. So just to mention a few of those trials. So what's new? Here we are in Scotland with approved new treatments, including first-line immunotherapy. We've seen these slides briefly last year, and a few will be probably very familiar. I've tried to simplify the slides here. And this is the Checkmate 743 trial, which has led us now to the approval of this combination of Ipi-Nivo, keeping it simple. So Nivo and Ipi are both immunotherapy drugs. They will help the body activate or enhance the T cells, or the certain cells in your body with part of your immune system. And this trial was obviously conducted in very organized fashion versus chemotherapy or standard arm with cisplatin and carboplatin. Cisplatin or carboplatin along with pemetrexed. So patients got platinum chemotherapy with pemetrexed, or they went on to get immunotherapy in combination with Nivo and Ipi. So it was a one-to-one. This is 50-50, properly balanced trial. Patients getting immunotherapy went on to get immunotherapy for 2 years, provided they tolerated it and didn't progress. And the patients getting cisplatin or carboplatin-based chemotherapy had no more than 6 cycles of treatment. So each cycle is about 3 weeks. So if you think about it, that's about 18 weeks of therapy compared to immunotherapy, where they may have had it for about 2 years maximum. So that trial, we know, gave us some very positive data and outcomes, even up to recently. The 3-year update figures have shown that even at 12 months, you can see the top line is that survival curve, utilizing the immunotherapy patients in the orange or red, if you see it more orange-red color. And the bottom line is the gray line, which is the patients who got chemotherapy. So already you can see at 12 months, if you drop the line vertically, you can see that the patients in the immunotherapy arm were doing better and surviving more so than those patients who are getting chemotherapy first line. And equally too, that benefit didn't disappear. It didn't wean off. It continued into the second year, 24 months. So you drop that vertical line again, you see that the red-orange line is looking better than the gray line. And that then continues again beyond to 3 years. And this is very much the kind of picture we see even in lung cancer and other cancers like melanoma, where if you're getting benefit from immunotherapy, it may be very much well sustained. Not in terms of a few months, it may be actually well sustained for several years. We don't have much more survival data beyond that yet. I'm sure, like in lung cancer, one day we will have 5-year survival data. But already you can see at 3 years, 23% of patients are alive, and 15%, significantly less patients are unfortunately alive with the chemotherapy arm. Just remember that some of those patients getting chemo would have probably gone into other trials as well, of which some of them may have ended up getting other forms of treatment, including second-line immunotherapy. So just be aware of that. So when we start breaking things down now, this is where it gets really interesting. And again, to a story similar to the patient who's just given us a story of having the biphasic or sarcomatoid types of mesothelioma, that when you break it down into subtype, you see that the epithelioid mesotheliomas still do better with immunotherapy. Not dramatically better, but still significantly better. And we can judge that based on the statistics. But the non-epithelioid or the biphasic equivalent or the sarcomatoid equivalent, you can see the big gap in that slide on the right now, where the red-orange line is well above the gray line. And at 12 months, at 1 year, 63% of patients are still going and doing well, with 33% of patients in the chemo arm are still alive. And that continues, that's sustained again, as we see at 24 months, 2 years, and at 3 years, 36 months. So clearly here in this subgroup of patients, this is a subtype of mesothelioma. This is where we saw the biggest gain, the biggest benefit in terms of offering immunotherapy as a first-line treatment option, more so than giving chemotherapy, which we knew over years, chemotherapy for the sarcomatoid subgroups or the biphasic subgroups didn't really ever work very well. So knowing we have immunotherapy as this option now is certainly something we'll always be talking about at our MDTs. Needing to know the subtypes of the mesothelioma really would help us in deciding and offering the best treatments for patients who have unresectable mesothelioma. Unfortunately, with treatment comes some side effects, that we call them toxicities. Side effects, serious adverse events, whatever you like, but the things we don't want to happen, and the things we get worried about as oncologists and things patients get worried about. But we have to remember that reporting side effects is also very, very important, so we can deal with the side effects. And the majority of the side effects of immunotherapy are dealt with effectively, potentially utilizing oral steroids, or if required, as inpatients, using intravenous steroids. But it's very important we get patients seen pretty soon, especially for the types of side effects, such as things like gastrointestinal side effects, where patients get colitis, or patients getting liver problems or pulmonary toxicities. They're all very important to manage. But as you can see, there were side effects, unfortunately. The more common side effects were that of skin dermatitis, like inflammation of the skin, and gastrointestinal, like inflammation of the gut. You think about it, the immunotherapy is working, so it activates your immune system. So it's enhancing your immune system so you can attack the cancer or help your body attack the cancer. But unfortunately, it sometimes does the same thing to your own healthy organs, such as your gut, such as your lungs, such as your thyroid gland. So these things are all possibilities. And fortunately, the serious adverse events are not in the majority of patients. And unfortunately, a few patients will end up stopping treatment, as we knew on the trial as well too. So just be aware. And these are the more common of the toxicities we noted on the Checkmate 743 trial. So I'll try to keep going. What if you did stop treatment, though? And what if patients did have to stop treatment, say, a few months into the treatment, and they were doing well, and they were having good response on their scan, or the cancer, the mesothelioma was stable? It's not such a bad thing stopping treatment, because interestingly, as we've seen in lung cancer as well, too, in some patients who have unfortunately had to stop treatment, we can actually see that there was actually a better survival compared to those patients who didn't have to stop due to toxicities. And a lot of different theories around that, but basically it's all about the immune system again, and activating the immune system. And probably the immune system got really, really well enhanced to enable the patient having the disease controlled for probably even better than those patients who didn't have to stop because of side effects. So we want all our patients to get the treatment. We don't want any of our patients to get side effects, but getting side effects is not such a bad thing. But reporting toxicities and side effects is very, very important. So in summary, these results from the Checkmate 743 trial did represent the first 3-year survival data with immunotherapy in first-line malignant pleural mesothelioma. Nivo and Ipi continued to provide durable and long-term benefits, as you can see from the red curves, really taking their time coming down. Unfortunately, there would be patients who would not survive beyond 3 years. But the 3-year data did show that there was 23% versus 15% respectively, compared to that with chemotherapy. Interestingly, 28% of responders have ongoing response beyond 3 years. So again, too, this is the durability and the effect of the immunotherapy on the tumor, and we see this in other tumor types as well too. So mesothelioma is up there with other tumor types like lung cancer and melanoma, for example, and renal cancers. Sorry, I just did that twice. So just to mention the second-line trial, so that was a first-line trial with immunotherapy, but in the second-line setting, we did have other trials which were positive as well too, reported last year or the year before at World Lung, and the confirmed trial was utilizing nivolumab immunotherapy, and that was a phase 3 trial, and that study demonstrated significant progression-free survival and overall survival benefits for patients with recurrent malignant mesothelioma, i.e. those patients, majority of them or all of them would have had platinum-based chemotherapy first line. So it's still an option, because we do have patients on the go who've had platinum chemotherapy first line. And there is a second-line option utilizing immunotherapy for those patients over the past year or two who may have treated with platinum chemotherapy first line. So there's another good drug, again, too. Venerol being mentioned based on the VIM trial, just reported in ASCO 2021, just last year. And again, too, a significant proportion of patients having some gain in terms of progression-free survival compared to active supportive care. ASC means supportive care. And those patients didn't do as well. But again, too, that's a promising second line or even third line treatment option. If you needed to consider, we would consider as oncologists all these different options now, which are pretty easy to get by, these drugs. And drugs like vinorelbine aren't very expensive, fortunately. So that's just a little slide there, again, a survival curve of the findings of the confirmed trial with nivolumab. And again, too, as you can see, the top line, which is the blue line on top, did better than the supportive care line, where patients in this trial were they were blinded. Nobody knew what you were getting, basically. So there was a placebo-controlled trial here. So basically, we try to be as objective as we can and prove that the immunotherapy patients actually did better. So again, to the median overall survival here in this second line. This is in the second line, not the first line. The second line treatment for these patients with 9.2 months median overall survival compared to 6.6 months. So that's quite significant. So the future in mesothelioma probably isn't as hard as it would have been in the past, and maybe it's not that hard a climb. Maybe it's a bit more smooth sailing, and the mountains are still there, but they're probably not as sharp to climb. And we'll take what we can with all the support we have available for patients and all the support that family and carers give to their relatives as well too. So it does look more promising, and the future seems a bit brighter now. So there is clearly options now for the unresectable mesothelioma group of patients, and already, as we've heard, ipi/nivo is going to be up there as one of our first-line, probably preferred treatments. Again, to taking into account that a lot of patients may have other comorbidities, cardiac or otherwise. Second-line treatment options are going to be there too. We still have platinum chemotherapy, don't forget. That could be used as a second-line treatment, for argument's sake, if you use ipi/nivo first-line. We've got drugs like vinorelbine. You could give them intravenously or orally if you felt otherwise, as I've done for a couple of my patients. And then immunotherapy, again, too, with nivolumab. If a patient has received first-line platinum chemotherapy. So again, too, it's an option as a second or third-line treatment, ideally a second-line treatment. So there are options there. There are options that we can sit down and talk to patients and family members about at our oncology clinics. What about appropriate patients who have early disease or even potentially resectable disease? Well, in lung cancer, as we all know, if somebody has a resectable tumor, they get it chopped out, they get it operated on. We haven't really done that much over the years with mesothelioma. And what if somebody did have an early resectable mesothelioma and were fit, pretty young and fit, or even if they were old and very fit? Would there be some degree of discussion between the different groups, the MDTs, our national Scottish MDT? We always consider this for patients who are potentially fit and suitably or technically resectable with a mesothelioma diagnosis, in particular the epithelial types of mesotheliomas. So this trial, called the MARS-2 trial, which is mesothelioma and radical surgery, was utilizing chemotherapy as well too. This trial we did recruit to, and we have successfully recruited over the years, and even managed to get closure of the trial during the pandemic and get to the target accrual. And this trial now is being analyzed in a lot of detail in terms of survival, in terms of quality of life, and it's available protocol on BMJ Open if you felt you needed to have a look at it. It was initially started as a feasibility trial, trying to get 50 patients in, the target of ultimately getting the trial to patients getting either standard of care with chemotherapy or chemotherapy with surgery in the form of what we call a pyrectomy decortication. It was a very, very balanced trial because, again, too, it was 1-to-1. It was 50-50. It was a randomization. No one particular person was choosing what patients got. It was a Bristol trials, the clinical trials unit at Bristol, where it was a randomization that took place, and it was quite balanced throughout the United Kingdom. And the target was made of 328 patients being randomized in this trial. And it was a very, very interesting time for mesothelioma beyond everything I've just said with regard to the new treatments, what this study is going to show and how this study may actually impact on how we change our management for patients, especially for those who have potentially resectable disease. The study is closed now. It closed a bit slightly later than planned. Survival data and quality of life continue to be collected, and the results are awaited in 2023. So with resectable mesothelioma in the appropriately selected patients, we can await those results with MARS2. Individual case-by-case considerations can be made with multimodality approaches being taken into consideration through the MDTs and the different thoracic units. Patients must be allowed to make informed decisions along with their carers and family, as there's still yet no data from a confirmed randomized controlled trial. We still don't have all the results yet. We don't have the data published yet or presented yet. But you can still have a discussion with regard to whether or not somebody did have something that was resectable, if it's appropriate to go for an operation. And our surgeons across the country are certainly willing to have that discussion. Future trials may incorporate novel approaches and immunotherapy, as we are seeing with lung cancer already. So in summary, we are really at a historic, pivotal time with mesothelioma. It's an important time, and treatment approaches are being really considered across Scotland. Immunotherapy now has an established role. Treatment options must be explored through our MDTs, and discussions with patients and carers is going to be very much the situation as we learn more. The possibility of radical approaches, we will keep an open mind and keep an eye out for, because that will be a very useful study to help us decide whether or not we need to be focusing on a radical approach. And research continues with every intention to seek better treatments and outcomes for patients. Great. I hope you followed most of that there. Thank you for your time there. I may have just stayed within time. I think we're going to go now to the Q&A session. And at this point in time, I'd like to reinvite Kevin and Selena, and we can take a few of your questions.